Good afternoon, everybody. I'll be presenting Inconspicuous on behalf of Medicine 4. So, ours is a case series comparison of two cases. One is the Mrs. N, 53-year-old female, a housewife from Vellore, who presented with complaints of cough with whitish sputum for the past 5 days, associated with weight loss of over 3 kgs over the past 1 month. Similarly, side by side, we have another patient, Mrs. H, a 53-year-old female retired teacher from Mizoram, who had presented with complaints of lower abdominal pain in the left inguinal region, particularly for the past 3 weeks, associated with burning micturition for the past 3 weeks. Their history was the first patient from Vellore who had presented with cough with expectoration for 5 days. She did not have any history of fever, preceding URI symptoms, blood in sputum, breathing difficulty. Was not there. She had complaints of loss of appetite and loss of weight. No other chronic history of diarrhea, black colored stools, evening rise of temperature, or joint pains were noted to support the loss of appetite and loss of weight. Past history is she has taken ATT for the past 2 years. For 2 years in 1996 for spinal TB, which was declared to be cured. She is a known case of diabetes since 2018 on oral antidiabetics. There is history of CAM intake for 2 years in 2018. Personal history, she is a vegetarian. The other patient, retired school teacher from Mizoram, who had presented with complaints of lower abdominal pain and burning micturition. She presented with burning micturition, lower abdominal pain, which was intermittent, moderate in intensity. She had no constitutional complaints of fever with chills, loss of weight, loss of appetite, no postmenopausal bleeding, no urinary incontinence, no prolapse. Past history, she was recently diagnosed with exocrine pancreatic insufficiency, for which evaluation was still undergoing. No other known comorbidities was there. She was a known case of status post hysterectomy, which was done 13 years back. She is a non-vegetarian. Further course, both of them were treated for their acute illness and the settings and were kept on follow-up in view of their persisting complaints. The first lady was treated with antibiotics for her LRTI, but she was kept on follow-up in view of generalized weakness and loss of appetite, and she was also advised further imaging and evaluation. The second lady was treated with antibiotics for 5 days outside itself. Her urine routine, urine culture then also was not showing any growth. It was treated. She was treated empirically. However, she had persisting complaints and had noticed swelling in the inguinal region, which was reported as enlarged inguinal lymph nodes, and therefore she had come to us for further evaluation from Mizoram. On examination, both the ladies did not have any significant findings other than enlarged inguinal lymph nodes, which were found in both the patients. First patient had an enlarged right inguinal lymph node measuring around 3 centimeter. The other one had a right inguinal, left bilateral inguinal lymph nodes, which are palpable. They were about 1 centimeter in size. No other systemic or general examination findings were positive in either of them. Investigation-wise, first lady was noted to have anemia with hemoglobin of 9.8, MCV of 76.9. The other cell lines were normal. There was mild transaminitis that was noted on LFT. LDH was just at the borderline, 245. HbA1c was 7.1 with pretty controlled sugars on routine monitoring as well. TSH was normal. She was noted to have iron deficiency anemia with a transferrin saturation of 10%. All her other investigations were normal. She was evaluated further in view of a loss of weight, loss of appetite, and the presenting complaints of cough with expectoration, sputum, blood culture. Everything was done, which was all found to be negative. However, her CT neck thorax abdomen showed enlarged right-sided common iliac, external iliac, and inguinal nodes measuring up to 3.5 centimeter. She was planned for a biopsy. Biopsy revealed features of mononuclear Hodgkin cells and Reed-Sternberg cells with foci of tuberculosis, which was suggestive of classical Hodgkin's with mixed cellularity. Similarly, our other patient, her blood investigations were similarly found to be very normal. No significant findings was there. Her HbA1c was also normal. She had mildly elevated LDH with a level of 349. With transferrin saturation of 14%, but there was no obvious anemia noted on the CBC. She was noted to have scanty fat globules. Stool elastase was, however, 101. Blood culture was negative. Urine culture was negative. She had undergone a PET-CT in view of the lymph nodes, which were already present on outside investigations. The PET-CT picked up metabolically active left lower para-aortic and left common iliac lymph nodes with subcentimetric bilateral cervical lymph nodes. Biopsy mostly showed adipose and fatty tissue, but the expert picked up empty mycobacterium tuberculosis, which was rifampicin sensitive. So in short, we had two patients who had come with rather vague symptoms and complaints. Only constitutional symptoms were present for either of them. And the only positive finding that were noted in both of them that was common was inguinal lymphadenopathy. So the first patient, the retired teacher from Mizoram, had presented with burning micturition abdominal pain, treated with antibiotics. In view of persisting symptoms, she had undergone imaging and biopsy was also done. Similarly, the other patient, she had presented with weight loss, cough with expectoration. She was admitted, treated with antibiotics, followed up with CT, and biopsy was planned. So, topic that I would like to highlight is how important is inguinal lymphadenopathy. Inguinal lymphadenopathy is something that we all tend to overlook because we consider it to be not representative of the actual infection that is going on. So what is the importance and clinical significance of inguinal lymphadenopathy? So the inguinal lymphatics and the structures that they drain. Basically, inguinal lymph nodes are two groups, that is horizontal group and the vertical group. Which usually drain the lower abdomen, external genitalia, anal canal, lower 1/3 of vagina, and the lower extremity. The differential diagnosis mostly are benign reactive lymphadenopathy, sexually transmitted diseases because of the inguinal region of involvement, skin infections, mostly of the lower legs, extremities, as well as and malignancies, lymphomas, squamous cell carcinoma of penis, vulva, anus, skin neoplasms, soft tissue, and Kaposi sarcoma. So coming to how do we evaluate a patient for lymphadenopathy? So history-wise, lymphadenopathy, localized lymphadenopathy, how do we evaluate? So history-wise, we have to exclude any infectious contacts, medications, travel, environmental exposures, occupational history, sexual history, and family history. Physical examination involves a complete lymphatic examination, regional examination, so as to rule out any regional cause of the lymphadenopathy. After this, it is basically divided into 4 sections: benign or self-limiting diseases, autoimmune conditions, suggestive of malignancy, and unexplained conditions. So in case of benign or self-limiting condition, if treatable, we treat it appropriately and keep a follow-up of persisting or changing lymphadenopathy. Non-treatable, reassure and explain the expected course of the disease. Autoimmune diseases or serious infectious causes, specific testing is done. If positive, treated accordingly. If negative, it goes into the unexplained criteria. Similarly, for malignancy, specific testing is done. Excisional biopsy is the standard for diagnosing any lymph node pathology. If negative, it goes into the unexplained category. If positive, it's treated appropriately. In case of unexplained causes, consider miscellaneous and unusual causes for which specific testing is based on the history and the area from which the patients belong. Other than that, review risk factors for malignancy, such as age, duration, exposures, associated symptoms, and location of the lymphadenopathy. If high risk, it is still said that we should go ahead with excisional biopsy for further studies. If it is a low risk, then we correlate whether it's a generalized or regional. Generalized, if it is generalized, then we go ahead with CBC with manual, other counts to rule out other systemic causes. CBC with manual differentials, rapid plasmid reagent test, PPD, HIV, HPSAG, ANA testing. If negative, biopsy the most abnormal node. If that is also negative, follow up for persistent or changing lymphadenopathy. If regional, the studies, the criteria says observe the patient for at least 1 month or 3 to 4 weeks for any worsening or increase in the size of the lymphadenopathy. If it resolves, nothing more to be done. If it is persisting, then biopsy of the abnormal node is what is indicated. So what are the risk factors for malignancies? Age older than 40 years, duration of lymphadenopathy greater than 4 to 6 weeks, generalized lymphadenopathy, that is 2 or more regions are involved, male sex, node that has not returned to baseline even after 8 to 12 weeks, supraclavicular location, systemic signs such as fever, night sweats, weight loss, hepatosplenomegaly. These are a few case reports of some of the cases that have been associated with lymphadenopathy. Unilateral inguinal lymphadenitis caused by Yersinia pseudotuberculosis, which is a case report that was reported. It is a pretty rare observation that was reported. Similarly, we have case reports about Kimura disease, which is a chronic eosinophilic granulomatous disorders, which is associated with the triad of lymphadenopathy, other peripheral eosinophilia, and other indolent swellings that are noted over the body. Cat scratch disease is also one of the common causes of lymphadenopathies. Just before closing, one final thing that I want to say, the take-home points are basically, when is it that we evaluate for lymphadenopathy? If it is a high risk for malignancy, is one of the main reasons when we evaluate for further causes of lymphadenopathy. which include male sex, age above 50 years, generalized in location. And lymphadenopathy, in contrast to the other lymph nodes, have to be much larger in size. In general, around more than 1 centimeter can be considered significant, but inguinal lymphadenopathy more than 1.5 to 2 centimeter is what is considered as significant. With that, I would like to conclude. Thank you.
Thank you, Dr. Kezia. Let's over to the floor for their comments and thoughts. Dr. Kezia, thank you very much. I have few questions to ask you. The first case had just cough with expectoration. It was more like an LRTI.
Yes, sir.
But you found on examination right inguinal node.
Lymph node, yes, sir.
Why did you proceed to go ahead with the CT scan?
So she was not initially planned for a CT scan. She was kept on follow-up only. Even at OPD basis, when she was still persisting to have that lymph node, is when we planned her for a CT biopsy.
What is that follow-up period you kept for?
It was around 2 weeks. Sir. She had already, when she had presented to us, it was already there for 3 weeks. Okay. We had already kept, and then we kept her for another 2 more weeks of follow-up, which is after which we went ahead with.
Were there constitutional symptoms in this patient?
She had a history of loss of weight and loss of appetite.
Can you? I think you should have given us more importance on that, because we see a lot of lymph nodes all over the place. But when we have to even 5 weeks, I think that constitutional symptoms is something very important. Did they have these symptoms?
Loss of weight, loss of appetite.
Night sweats.
No,
Okay.
sir. No night sweats.
It would have been nice if you had told us how much weight loss had happened, because that actually pushed you to do that, right?
Yes.
In your second case, again, it was more like a UTI.
Yes, sir.
And then you had this bilateral inguinal lymphadenopathy.
Lymph node.
And what made you in that case to go ahead with your CT scan?
So she had already come from outside with imaging, which was supporting lymph nodes, which were noted in the inguinal region and abdominal, intra-abdominal nodes as well. She was actually a private patient. She had come from Mizoram all the way just for the evaluation of this lymph nodes.
Okay. In that Mizoram patient, I did not see on your PET scan the inguinal node. Can you just go to that slide? No. Is there inguinal nodes mentioned in your?
The left common iliac node, sir.
Okay, sure. It's iliac nodes, not inguinal.
Not it was.
Okay. No, because you said that you felt inguinal nodes, but there's no mention of the report. Instead, it is iliac.
Iliac.
So there's a little bit of discrepancy there. I want to ask you, how do you choose between CT, neck, thorax, abdomen versus PET CT? How do you take a call on that? Are the costs different? So how do we go ahead? Which is cheaper or approximate cost? Do you know?
PET CT would come around to 25,000 totally. 22 to 25 is. PET CT,
neck, thorax,
abdomen comes around to, not very sure, 80.
So about 4,000 to 5,000 rupees difference?
No, more than that. Around 8,000 to 10,000 rupees would be difference.
In your clinical examination lymph node, especially the one from Mizoram, did you have matted nodes, fluctuating nodes?
No, so they were firm nodes, not adherent, they were mobile nodes actually.
Okay, because the important thing is inguinal nodes we see. And often when you see that for the first time, you look whether they're wearing footwear or not. Those are things that we normally look for.
Yes.
But I think it's the constitutional signs which force us to take a big test. And that is the message, not mere persistence. In both the cases, the percentage of weight loss over what period, other constitutional symptoms, they take more this.